السلام عليكم. هنفتتح إن شاء الله المؤتمر ده الفيرست كورس بعنوان Practical Approach to Renal Transplant Immunology. طبعا هنبتدي بآيات قرآنية.
بسم الله الرحمن الرحيم إنا فتحنا لك فتحا مبينا ليغفر لك الله ما تقدم من ذنبك وما تأخر ويتم نعمته عليك ويهديك صراطا مستقيما وينصرك الله
نصرا عزيزا. صدق الله العظيم. ثم السلام الوطني لجمهورية مصر العربية. اهلا بيكم في المؤتمر الاول او الكورس الاول للاميونولوجي مع الترانسبلانتيشن مع النفرولوجيست، وطبعا بيشرفنا لفيف من الاساتذه. وانا هبتدي بسيكونس القعود. طبعا كلهم اساتذه كبار ويعني يستحقوا كل شكر منا على تشريفهم النهارده. هنبتدي الاستاذ دكتور طارق الباز. انا برضو هتكلم بالانجليزي بقى عشان احنا معانا ناس اونلاين كتير من بره مصر. It's my honor to present Professor Tariq Elbaz, Professor of Nephrology at Al-Azhar University. He is head of the Arab Society of Nephrology, and he's also one of the initiator of the transplantation course in the Arab Society of Nephrology in collaboration with Liverpool. Professor Tariq.
Thank you very much, Professor Magdi, and really congratulations on this great effort. We have a lot of eminent professors today, all of which are landmarks in transplantation immunology, particularly Professor Medhat Askar. This is something very important, and I really admire what you are doing, because to be a good clinician in transplantation, you have to have a good background in transplantation as well. And during the fellowship course, we have the first module, which is totally directed to immunology. It's rather tough, yet a lot of students now are grasping a lot of knowledge, and they are very happy, and I'm surely after they finish the 6 modules, it will be a real great add-on. So what you are doing is fine and in collaboration. Thank you very much.
Thank you, Professor Tariq. It's very good course, and I think all who witness this course will appreciate it later on, as Professor Tariq mentioned. It's also my honor to present a dear friend from the United States, Professor Medhat Askar. He is an immunologist. He's an Egyptian like a pyramid in the United States in immunology. Is a well-known figure. Is a professor of immunology and transplantation, not just renal but organ transplantation. He has also worked in CDC during the COVID era. He was the head of laboratory, if I remember, of COVID in the CDC, and he is also director of transplant lab in Dallas, United States. Professor Askar.
Thank you very much, Dr. Magdi. It is really an honor for me to be here, and I have very strong ties to Ain Shams University where I graduated and the Azhar University where I got my master's and PhD. So I'm very honored to be part of this course. Thank you. Of course, of course.
Thank you very much, Professor Medhat. And now Professor Hisham Said. Professor Hisham Said is the Vice President of the Egyptian Society of Nephrology. He's an eminent nephrologist in Ain Shams, and he is always in the education effort. And I really thank him today because of his collaboration with us.
Thank you, my friend and colleagues and all of the audience. It's my pleasure to be here for the practical. And I like the practical approaches, so we have to put that in the course of the educational program. Secondly, I have a message to all of the juniors and nephrologists that transplantation program should be an option that should be put for all patients with end-stage kidney disease, and dialysis should be just a bridging for a successful renal transplantation. Hopefully that all are going well and all are being very fruitful and very illuminating talks. Thank you very much.
Thank you very much, Professor Hisham. And now Professor Gamal Saadi. Of course, again, is an eminent figure in nephrology in Egypt. He is head of the African Society of Organ Transplantation and ex-president of Egyptian Society of Nephrology. And in the field of transplantation, he is a pioneer in research.
Professor Magdi, let me not to congratulate you or Ain Shams for this course. Let me congratulate all of us and Egypt for this very eminent and very peculiar approach to educate the young generation. Let me first welcome Professor Maya Hasaballah, President of the Egyptian Society of Nephrology and Transplantation, Professor Tariq Elbaz, President of the Arab Society of Renal Nephrology and Transplantation, Professor Medhat Askar, the Secretary of the TTS, and looking forward to see you as President of the TTS, inshallah. He is a very eminent person and doing a lot of effort, and hopefully, inshallah, he will be the coming President, inshallah. Dr. Hisham Said is a peculiar figure in nephrology and dialysis, and as well in transplantation. Professor Hani Hafiz recently is the president-elect of the AFRAN, and we are doing a lot of effort regionally, not only in Egypt. And I would consider harmonizing all our efforts in a common pool or a common harmonized effort under the guidance of the Egyptian Society. So let us regulate all the courses to put them in one frame. And congratulations for all your efforts. Thank you very much.
Thank you very much, Professor Gamal. And we have with us, of course, Professor Hani Hafiz. Again, Professor Hani is an eminent figure in nephrology in Egypt. He also is the ex-president of the Egyptian Society of Nephrology, and he is now the president of the African Society of Nephrology. And we hope during this his leadership in Africa that will bring Egypt back and bring Africa back to us. Professor Hani.
Thank you very much. It's a great honor and privilege to be today, and congratulations, Professor Magdi. We were acquainted in the last years that every year you perform an admirable congress on dialysis. And now you are adding to this also transplantation immunology. So you are talented in all nephrology branches, doing very advanced education, because it was always the clinical nephrologist has some gap in catching the basic immunology. So I think with these courses, we are covering this gap, and we are allowing the clinical nephrologist to understand all the details and to understand the weapons that they are using in the treatment in depth. And of course, we are having the eminent Professor Medhat Askar with the TTS support and with his continuous education. By the way, Professor Askar is also responsible about the education in the TTS. And all our eminent colleagues, Professor Tariq Elbaz is now with Professor Halawa doing a very great job in an academy for continuous education. Professor Gamal Saadi is doing a marvelous congress after 10 days for the organ transplantation. Professor Maya Hasaballah will do after 1 month the Egyptian Society and Nephrology annual congress in City Stars as usual. So this plethora of scientific activity is, I think, should be grasped very well from the junior as well as from the senior to update their knowledge. Thank you very much.
Thank you very much, Professor Hani. And we welcome Professor Maya Hasaballah, President of the Egyptian Society of Nephrology. Professor May, of course, all of us know her, and everywhere she is a prominent nephrologist and educator from Qasr Al-Aini School of Medicine. Professor May.
Thank you very much, Professor Magdi. Really, this was a great addition to focus on immunology. And this is a very important branch that needs to be well understood so that you can understand all the rest. You can understand the treatment and the clinical picture and the labs, everything when you understand this thing. So I hope this is going to be a good start in a chain that will continue. Maybe we can then discuss the immunology of glomerulonephritis. Maybe we can then do some conjoint meetings with the rheumatologist, etc., and so on and so forth. So thank you very much for this new innovation. Thank you very much.
Thank you, Professor May. It was inspired by Professor Medhat Askar, and we worked hand in hand to make it happen. So I think we have to thank him for his effort and his time. We have also Professor Yasser Sliman. Professor Yasser is a professor of nephrology at Shams University. He was the vice dean of Faculty of Medicine at Shams University. He was one of the director of the transplantation program in Shams University, and he carried this for more than 7 years, and he was one of the finest physicians in transplantation I worked with. We learned from him a lot. Professor Yasser.
Thank you, Professor Magdi, for this eminent event. Practical approach to clinical immunology or immunology of transplantation to keep us sharing experience with our professors in Egypt and abroad, like Dr. Medhat Askar, Dr. Ahmed Halawa, and others. Actually, we are in need for junior staff to give an idea about the immunology of transplantation and to get experience from their professors about the field of transplantation, which is slightly missing in the junior staff in Egypt. Thanks for this event, and I hope it will be a fruitful lecture and sharing experience. And thank you, Dr.
Thank you very much, Professor Yasser. And I would also to hear from Professor Khalid Abu Saif. He just joined the ethical committee of organ transplantation in Ain Shams University, and I think he will add a lot to this committee.
شكرا استاذ دكتور مجدي، وببارك طبعا على التنظيم الرائع والافكار. دايما زي ما الزملاء الافاضل قالوا innovative in English. Okay. Dr. Magdi is always innovative, and I think I'm thankful for his arrangement, and I want to have a very good meeting today, inshallah.
Thank you very much, Professor Khalid. مش هقدر اطلع غير على السلم طبعا. So I think we have also to thank all the immunologists that joined us today. We have an eminent professors from Ain Shams University, from Cairo University, from the military university now, and we have also colleagues, Professor Kamel, Vice President of Tanta University, Professor Tariq Tantawi, a lot of friends, Professor Iman Sarhan, one of the pillars of Ain Shams, and Professor Walid Ab Mohsen. He's a dear friend, and he's a very supportive to transplantation in Ain Shams University. And now we would like to hear from our eminent professor, Professor Waida Shinawi. She is the head of renal unit and nephrology department and Shams University. She supported this meeting, and I think we need to hear from her. Last but not least, Professor Waida.
Thank you very much. صباح الخير عليكم جميعا. Good morning. I hope this will be a very useful meeting, and hope to continue every year this with the great effort of Professor Dr. Magdi and our dear colleagues. Thank you very much.
Thank you very much, Professor Waida. In just 5 minutes, I will just illustrate the nephrology Ain Shams renal transplant program. Professor Mahmoud Al-Mitaini should be with us today, but he has commitment with the president of Egypt in Sharm el-Sheikh, and he will come tomorrow, inshallah. And also Professor Sabri Gohar, one of the eminent professor in Ain Shams, also has a social event today. So Ain Shams University, this is the team of Ain Shams. Most of us in this picture, we started the first transplantation in 1976, but was sporadic cases, and we started regular transplantation in Ain Shams University Specialized Hospital in 1986 till 1990, when we stopped for some time and we resumed transplantation in 2006, thanks to Professor Yasser Sliman. He was the leader at that time. And of course, in 2010, Professor Al-Mitaini initiated the organ transplantation unit in Ain Shams University according to the new law of transplantation, of organ transplantation. And ever since we started transplantation in our university, we have the honor to have learned from Professor Sabri Gohar, who has transplanted almost 2,000 cases in Insurance Hospital, or supervised more than 2,000 cases in Insurance Hospital. The late Professor Assam Khidr, Rahmatullah alayhi, Professor Assam also has a great experience in transplantation, maybe more than 1,000 cases. And of course, Professor Yasser Sliman, from him we learned how to do transplantation at Ain Shams University. And he was supervisor of Ain Shams unit for a lot of years. And then it was me, unfortunately, until now. And then in Ain Shams University, we have a lot of interested physician, nurses, and dedicated workers to work together. We have started our unit, which is not a department, under Professor Mahmoud Al-Mitaini, of course. And we have a lot of colleagues working with us. Of course, we have a great urologist, Dr. Ismat, and Dr. Talib Abdelazim from vascular surgeon. We have performed 220 cases from 2006. Before that, there was no recording of the cases, but we have records now for all our patients. After 2010, we have only transplanted 2016, we only transplanted living-related donors, and we have some strict regulation for transplantation in Ain Shams University. I won't go into the details, but we have a lot of interesting cases that we will discuss this meeting. The ratio was increasing until the COVID era, when we suffered altogether with less patients. We have rejection mortality rate of 1.6, and we have a rejection rate almost 3 to 4%, 2.4%. But we have a lot of success. We have performed simultaneous liver and kidney transplantation, and all this is dedicated to our professors and colleagues who worked together. Nurses, physicians, social worker, and thank you all. Now we move to the first session. So we have to switch the chairperson and to start the first session immediately, because we have commitment with the Zoom meeting. مين الفيرست؟ دكتور مدحت هيبتدي. وهنديله وقت زياده.
Bismillah ar-Rahman ar-Rahim. We have to start our session now, and it's my honor to present Professor Dr. Midhat Askar. He will discuss about the basics of immunology of allograft rejections and tolerance. I think this is the pearl of the immunology and transplantation. Please go ahead.
مش موجود في مصر. لا موجود قاعد هو مقيم في السخنة، هو قاعد عنده الشاليه بتاعه وقاعد في السخنة. اكيد موجود.
السلام عليكم. Good afternoon. Thank you, Dr. Magdi, for this opportunity. It's actually the idea of this course came about when we were discussing how worldwide, not just in Egypt, that most clinicians find immunology to be a challenging subject. And we thought, is there a way that we just focus on the immunological aspects or immunological attributes that has direct implications to practice. And this hopefully will be the spirit of this course, and I will try as much as I can to tie all the content I will be presenting to clinical practice. So I will talk a little bit about antigen recognition, antigen presentation, innate and cell-mediated and antibody-mediated allograft rejection, and mechanisms of common immunosuppressive agents and mechanisms of tolerance. And I will end by sources of allosensitization. So if we think about why organs get rejected, it's actually from the moment we conceive the idea of transplant, and everything is in a conspiracy to sabotage this process. It starts from the donor, especially if it is deceased donor, where you have major trauma event, and however it is live donor or deceased donor, there will be ischemia, reperfusion injury. So that's on the donor side. On the recipient side, we are not starting with a healthy subject. We are actually starting with someone who is with end-stage organ disease. Whether it is end-stage renal disease that is on dialysis, or on or end-stage heart failure, who is on mechanical circulatory support, and all of those induce pro-inflammatory environment. And then the actual process of transplantation, which depends on which organ is being transplanted, also induce intraoperative stressors and release of cytokines, pro-inflammatory cytokines. All of this will set a hostile environment against the graft before we even start the graft functioning. Reperfusion is going to be another insult in the post-operative period. And then if we are starting with antibodies, however we know about or we don't know about, because we test only for the things that we know. The HLA is the major recognition antigen in solid organ transplantation, but by no means is it the only target for allorecognition or even immune recognition. There are many non-HLA targets. Some of them are polymorphic. They are different from one patient to another, and some of them are even monomorphic, like autoantibodies. And all of this would precipitate acute rejection. You add to salt to the wound if you have infection, which is part of the process because we immunosuppress these patients. So infection in itself adds to the hostile pro-inflammatory process. And after that, it is inevitable that all these injuries gonna eventually heal through a repair process that is gonna involve some degree of fibrosis that is gonna lead to chronic dysfunction. I'm going to mention how this is relevant to the clinical outcomes. For example, we talked about how that the transplant status of the recipient can affect that. For example, if patient is on dialysis, is going to have worse outcomes than patients who start preemptively. We talked about the donor and ischemia. So the longer the ischemia time, the more opportunity for this hostile environment in which the organ is being subjected to, which is going to eventually lead to worse outcomes. So we can see clearly that in the orange curve, up to 36 hours, and that's mainly in deceased donor, you would see that there is a significant worsening in outcomes when you exceed 36 hours, and it becomes almost unacceptable if it is after 48 hours. And that also explains, at least in part, why living donors have a significantly better outcomes than deceased donors. So this is how we tie basic immunology to explain the differences in clinical outcomes that we see. When it comes to antigen recognition and antigen presentation, so so this is not a kidney, this is the lymph node, and you have the afferent lymphatic vessels, and here the efferent lymphatic, where the antigen comes to the regional lymph nodes and activates the naive T cells and naive B cells, and naive B cells starts to proliferate and gets activated and leads to germinal center formation, and then it leads to plasma cell formation. And some of them gonna be transformed into memory B cell that is going to continue after the initial event. And we mentioned the innate immune responses. And it is really important to keep this in mind, because all the efforts we do in terms of matching and cross-match and all of this, it really doesn't address the innate immune responses. So those are going to take place no matter what. Hopefully, with effective immunosuppression, we limit the damage that is caused by those. So we have a host of cytokines, chemokines, small molecule mediators. We have innate immune cells such as neutrophils, monocytes, NK cells, and we have antibodies that are not particularly against HLA, and of course we have the complement that works on all antibodies, whether HLA or non-HLA, and we have targets like the endothelial cells and anti-endothelial cells, and their role in rejection is very well established. I don't want to confuse the issue and make it sound like it's free for all and it's just doing HLA doesn't matter. So if your patient is gonna reject more than, and there has been studies that looked at that probably more than 90 to 95% of the time is gonna be due to HLA antibodies. However, we really need to remain mindful that there could be other sources for or other targets for immune recognition that could lead to rejection. And part of the innate immune responses is the dendritic cells that also are active in presenting antigens. So all of this is on the innate immune response that is not addressed by any testing we perform pre-transplant. In the adaptive immune response, there is actually, it will be interesting to know that for B cells to become activated, B cells do not get to play until they interact with antigen-specific activated T cells. So that's why it is not surprising that in histopathology, there is always a shadow, or not uncommon to see a shadow of cell-mediated rejection in cases of antibody-mediated rejection, because antibodies would not even come to play if T cells were not activated. And then these T cells would directly attack the graft, and the B cells, through interactions with dendritic cells and CD4 helper cells, they turn into B cell blasts and plasma cells that will produce the antibodies or turn into memory B cells. What's interesting here is that in our testing, we don't test for T cell allosensitization. And this is not just here in Egypt, that's worldwide. Not because they are not important, but simply because we don't have robust enough reproducible clinical tests that would measure T cells in a reproducible way. So there are ELISpot, and there are some of the tests that are performed on research basis, but they are not reproducible enough to be performed as a clinical test for standard of care. And then B cells that get stimulated in this environment have some career choices to make. Some of them, the majority of them actually are turning into short-term plasma cells, short-lived plasma cells that will produce the HLA antibodies and all other sorts of antibodies like anti-endothelial and anti-angiotensin type 2 receptors and all HLA and non-HLA antibodies. And some of them gonna turn into memory B cell, and some of them gonna be long-lived plasma cells. And these long-lived plasma cells are believed to reside in the bone marrow niches. That's why the patients who are highly sensitized and having 100% PRA are very hard to desensitize, because these cells are usually immune against most desensitizing agents. And as you can see, the antigen presentation process, the more mismatches, the more chances for antigen recognition, antigen presentation, more targets for immune injury. That's why the more matching we have, or the more mismatches we have, the worse outcome we will see. And this has been, there was the notion at some point in time that probably this is with improved immunosuppression, the effect of HLA matching on graft outcomes is diminishing, but actually that is not true. It remains until very recent cohorts, transplants performed in 2017, so this study that was done in 2021, where you see the 3-year outcome is still, you see the same effect between 0 mismatches and 6 mismatches, about 10% decrement in outcomes. So now someone would ask, so then we should match everyone, right? If we have such important impact, we should wait for the perfect match. The problem with doing that is that the mortality on dialysis is significantly higher than the worsening of outcomes. So the patient's chance of living with a mismatched transplant is significantly higher than staying on dialysis. That's why in the United States, matching is not the primary factor in allocation. The primary factor of allocation is absence of unacceptable mismatches, is absence of non-specific antibody. And when everything is equal, we prioritize those who are matched. This is just a reminder of the differences between when you have no mismatches in animal model, which is very reductionistic, but just to convey the idea, then the graft is being tolerated in syngeneic mice model. If you have allogenic model, then you have rejection. But if you have a second or a re-challenge with the same antigen, you would have significantly more accelerated rejection, because all the process of antigen recognition, antigen presentation is already skipped. The immune system already knows the antigen. We have memory T cells. And the direct implication of this is that when we are in a retransplant context, if we are mismatching for the same mismatches, then we need, I'm not saying that this is shouldn't be done. I'm simply saying that this is a higher level of immunologic risk. And in these cases, we need to be probably use more augmented immunosuppression. We use induction, or we become more diligent in monitoring post-transplant for HLA antibodies. And if we look at the outcomes between first and second transplant and subsequent transplants, in most studies, there wasn't a difference between first and second transplant because probably clinicians are mindful of this fact and they are correcting for this by adjusting immunosuppression. But for subsequent transplants, and that's why not many places in the world do third kidney transplant, no matter how you adjust, it's just the immune response is so robust that you will not be able to overcome it with immune suppression.